Okay, so as a session kind of plan, what we're going to go through are looking at where some challenges for general practice might come and identifying those, talking about the concept of resilience and how to apply that, then changing tack a little bit, looking at how both general practice and the NHS hospital contract work with relevance to your future life as a GP. Then to finish off, there's a section on putting the pride back into your practice. So this is based largely on a session that I've attended by Roger Neighbour, who you might remember from all your medical school and GP training communication sessions. And lastly, if you've never done it, I'm going to try and take you through a mindful exercise, something similar to what I do myself and I do with my patients, I think quite successfully. Hi, so this section of the presentation is kind of a bit about remembering why you've become a GP, and this is based on a session I went to that Roger Neighbour, who you may remember from quite a lot of like educational stuff, consultation models, that kind of thing. It was a talk he did as part of a conference company. They come and do these, so you may see this around, and it's called Preserving the Pride in Your Practice. So if you see him come around, I actually thoroughly recommend it. It really helped me remember why I became a GP and why I kind of enjoy it really. So hopefully I'm going to be able to impart that same enthusiasm onto you. I think a really key thing to remember as part of this is, if you've never seen this before, it's called Maslow's hierarchy or triangle. The idea being that you kind of have to meet the base level needs of a human being before you can move on to the next bits. And sometimes as doctors, we can forget the fact that we've not set the baseline for someone, or we didn't realise that that was actually an issue for them, which is why we're struggling to get any further. So if you've got a patient, for example, who's homeless, has got nowhere to live, nowhere regular to eat, anything like that, you're never going to really be able to work on their self-esteem, their respect for others, their self-worth in a sense, because the base needs haven't been met. So actually the first thing you need to do is to say refer them to a food bank, make sure they're involved with the homeless service so that that gets sorted, and then you can actually start to build upon those things. And if you think about patients in that sense, sometimes we're trying to meet needs that we think need addressing, like their psychological needs, or trying to get them to understand why their chronic disease is important. You might be struggling because actually there's a base level need that needs looking at first. And in fact, you can apply it to your own needs actually. So you think about your job satisfaction, what you're enjoying. You know, most of us have achieved that survival level thing. So we've got the basic qualifications, but actually even in ST3, you haven't got the basic qualifications. You're still maybe trying to achieve those with CSA. And even when you have got that base level, it doesn't always feel like you do. So sometimes it's really important to remind yourself, I have got the qualifications deemed necessary to do this job, not only on a national, but bear in mind that your RCGP qualification is an international qualification in a lot of countries too. So remember that you've got that, but you can do this job. So when you're having a bad day, that's something to bear in mind, remember. And you probably do have most of the skills and knowledge as a result of that training. The thing that often starts to become difficult is feeling appreciated and feel like you enjoy working with patients. And if you're having particularly bad times, sometimes it's really important to go looking for good feedback. You know, listen when patients say nice things to you. You know, and there are ways of getting that good feedback from people. If you don't feel like you're getting it. If you feel like you're doing a good job, you will feel better in yourself and you'll feel like it's worthwhile. And once you're in that kind of place, actually often that's a time when you can start to make a difference on what you do. So your sense of self-worth is improved, so you make positive changes to your work, and that then brings to it a sense of fulfillment. So again, the idea of this hierarchy is just remembering to go back to that base level of things and remind yourself that you've got all the qualifications, the skills needed to do things, that you are appreciated in what you do. Recognize that you are worthwhile in that, and from that comes increased sense of self-worth and esteem. So let's take a case. Hopefully this patient will be recognisable to all of you. Ida, who's 82, is coming. She's got a long list, doctor, of things she needs to discuss. So what goes through your head when you see that on the list, or she says it when she walks through the door? Have a little think about what the feelings that you'd have at the thought of this woman shuffling in. I'm going to guess she's one of these ones that wants to take off her coat and hang it on the coat peg. She might even have brought a book or a daughter with a list, just to make sure she doesn't forget anything. How do you feel right now? I think it's probably safe to say that most of us had a sense of dread at the thought of this patient coming to sit in with us. And it's important we acknowledge that that's what's going on there. And that's because of this model here on this slide, is that actually a consultation, we do an awful lot of talking about the patient, you know, what they need to tell us, the golden minute, they've got all this kind of stuff. And it's almost sometimes we feel we don't have the right to reply. But it's really important to remember that most consultation models, we really focus on learning the patient side of it, but we sometimes forget that there is a doctor's part of things. And actually, the whole idea of shared care is not that the patient dictates what's going to happen and has the say all over everything. It is shared. We too, as doctors, have the opportunity, and it's required that we are part of that model of delivery of care. So yes, it's really important that the patient feels like they can disclose all the information that they need to and get that out. And part of allowing them to give that story establishes the rapport between us. What's quite important though, and sometimes we can forget to do in our desire to let the patient talk, is to remind the patient that the goal of this consultation is that we understand what they're saying. So it's okay to sort of, if someone's been going on for more than a few minutes, to interrupt and say, what I really need to understand is how this pain stops you doing things, or what I really need to understand is why you presented with the cough today, given that you've had it for 9 months. These are the bits that help me understand as a doctor what I can do for you. And so by clarifying and really going in to dig deep on the bits that we need to know about, we show the patient we've listened to them because we're taking on bits they've said, and we're taking it and showing them how we need to understand that information. So that's the doctory medical bit of things. And once we've done that, that's when we come up with our shared management plan of what we're going to do. And because we've taken from what the patient said, we've given them their chance to say things, but told them how we want to hear them, the patient feels helped, and hopefully we feel satisfied because we've done our doctor bit and we've signposted our doctor bit. And I think this is sometimes where things can go wrong, is where we just keep listening to the patient and we don't actively listen to them. And actively listening allows us to talk with the patient, to the patient, to harness what the raw data that they've got into information we can synthesize to something useful. So kind of in short, you have got to pay attention to that person. There's no getting away from the golden minute of things. But we need to remember we need to move from the patient's part to the doctor's part of the consultation to get that extra understanding that helps us make decisions. So what's really important is giving people receipts. So if we start immediately launching into a very paternalistic style thing and talking at a patient, they can feel not listened to. And that's not actually that satisfying as a doctor either, I would personally say. So we need to make it very clear to them what we're doing as we're doing it. So repeating back to one, so it sounds like you've had this cough for 9 months and it's really bothering you, and the reason you've come about it today is because you've now started to cough things up and you're worried that that's an infection. So there's your receipt to the patient. I've listened to what you've said, I'm taking it on board. And then think aloud with the patient as part of the plan. If they know why you're thinking what you're thinking, that will really help them understand your thought process. So if you say to them after they've had that cough and they think it's an infection, but you don't, because why are they now just having sputum? You think it's COPD that they've started manifesting signs of. They've probably been, mildly COPD for months, not bothered them, they've not come in, but now they have because they're probably now moderate COPD. Well, let's tell them that's what we're thinking. So I don't think you've got an infection, and it's because you've had the cough for 9 months. There is no infection that lasts for that long without getting better. And yes, sometimes sputum is a sign of infection, but in this case, I think it's because you've got something else that I want to investigate. And this is what I think we do to prove that right or wrong. We're going to get a chest x-ray and do some spirometry. I'm going to give you an inhaler to trial out and see if that makes your sputum better or worse. If it's not working, or some of your tests up, you might have an infection, well, it's been safe for 9 months for you, so we can wait another week or two to get some tests back to make sure that we're treating the right thing. So in that example, we've addressed their worry that they've got an infection. So if they go away without antibiotics thinking we're useless, well, hopefully now they don't, because we've told them why we're not going to do that. And that's the kind of key aspect of this kind of consultation model, is about really showing the patient that we're listening, to enable us not to have to listen to the entire list and story forever. That's the idea of that, really.